thank you everyone for allowing me into your bedroom, lounge, office, wherever you are sitting tonight in the unusual way we're doing teaching these days. Tonight I'm hoping to give you an update on diabetes and pregnancy and hopefully making it more relevant to you in primary care. So I'm not going to talk a lot about what happens in the hospital setting, but more about your role before pregnancy, during and after. I will first talk about pre-gestational diabetes, go over a little bit of background information, also some new technology, and then hopefully some sort of checklists in terms of what you can do before, during and after. And then I'll apply the same to gestational diabetes, and then hopefully if I talk quickly enough, there's some time for questions at the end. All right, so pre-gestational diabetes. So that's obviously the group of women who have diabetes before pregnancy or outside of pregnancy. A much smaller group of women, but much more resource intensive and higher risk pregnancies. We consider that's including the type 1, the type 2, and the other group. So just some numbers here. So this is data from the 2018 New South Wales Mother and Baby update from New South Wales Health. And as you can see for pre-gestational diabetes, if you go back to 12 years to 2008, 0.6% of pregnant women had pre-gestational diabetes. And through to 2018, 10 years later, 0.9. And looking along the way, it hasn't changed a lot, so that's not overly surprising. The New South Wales Mother and Babies didn't collect any data on the different types of pre-gestational diabetes to 2016, so we've only got those numbers for recent years. And as you can see, the type 1 category, it's pretty well much the same. Type 2, even though those numbers are small, they are going up a little bit, and that's not surprising considering women are having their babies older, women with higher BMIs, and within Australia we're much more ethnically diverse. The type 2 group are the ones that may be managed by yourselves and not have any involvement with hospital settings or endocrinologists. So that's particularly the group where we really need your help to get them engaged with pre-pregnancy care. Type 2 diabetics has just as many complications as the type 1s, and sometimes they're a little worse, as they often have comorbidities associated with type 2. All right. Now, going back in time, so the St. Vincent Declaration in 1989 was made when the WHO, the International Diabetes Federation, and a whole lot of government health officials from Europe gathered in this town called St. Vincent in Italy. They identified that diabetes was a major health concern for all adults and children with diabetes, and they set some targets and goals. And the target or the goal they set for pre-gestational diabetes was to achieve pregnancy outcome in the diabetic woman that approximates that of the non-diabetic woman. And to this date, 31 years later, we are still not doing very well. So these women still have more complicated pregnancies and worse outcomes. All right. So just a bit of background, just a reminder of what the risks are for women with pre-gestational diabetes. So these are the maternal risks. So as you can see, miscarriage rate much higher. Again, it is control dependent. If they've got good control, it will probably mirror the background rate, but the worse their control is around conception, the higher the miscarriage rate. Much more prone to hypoglycemia, particularly in the first trimester of pregnancy, so that can affect 20% of women, whereas obviously the non-diabetic population that virtually never happens to. Retinopathy and nephropathy, they'll often come to pregnancy with some background disease which can worsen unless there's really good control. And preeclampsia or gestational hypertension risk is about 3 to 5 times the background risk, so they've got about a 12 to 15% chance of getting that in pregnancy. If they have poor control in macrosomia, then they're more prone to instrumental deliveries and associated perineal trauma or oasis injuries, and a really high rate of Cesarean section in this group, sort of 30 to 50%, so that's 3 times higher than the background rate. 20 to 25% of these women will deliver prematurely, and usually that's iatrogenic. Usually we have to deliberately deliver them early because they've developed complications, and that's 4 to 5 times higher the background rate. And all these women are prone to delay in lactogenesis too, so they're less likely to successfully breastfeed, which means they and their babies will not get the standard benefits of breastfeeding. Now, moving on to the fetal or neonatal risks. So congenital anomalies, again, a big range between 5 and 18%, and that is very much control dependent as well. I quite like this graph on the left. If you look at that one, that looks at what the woman's HbA1c is and what her chance of having a fetal anomaly is. So we like pregestational diabetics to have an HbA1c around conception of 6.5% ideally, or even less if they can, which gives them a 1 in 33 chance, or about a 3% chance of a congenital anomaly, and that's pretty similar to the background rate. But as you see, each percent you go up, if you go up to 7.5%, it's 1 in 20, so that's 5%. 9.5%, 1 in 10. So you're almost doubling her risk every percent she goes up with HbA1c, so control's really vital from that point of view. I sometimes find this graph is quite useful to show women beforehand. Fetal growth restrictions, so poor control can affect the quality of placenta, and so sometimes we can have small babies. Not as much so as the macrosomia. Obviously, if we have poor control, about half of women have macrosomic babies. That's 12 times the background rate, and this can lead to operative and instrumental births, birth injury, shoulder dystocia. I've already mentioned prematurity at about 20%, and the stillbirth and perinatal mortality rate is about 2 to 5 times higher the background rate. Now, again, that can be improved by control around conception and during the pregnancy. But even if women have very good control, their rates still seem to go up after, their stillbirth rates still seem to go up about after 38 to 39 weeks. So in this group of women, we still tend to electively deliver them at 38 weeks, even if they've had very good control. These babies are prone to polycythemia and therefore jaundice, requiring phototherapy and requiring nursery admissions and separations from mums. They're much more prone to neonatal hyperinsulinism, which causes hypoglycemia, so 25 to 40%. So they'll often need to be separated from mum, admitted to the nursery. And that neonatal hyperinsulinism also has an effect on lung maturation as well. So these babies are much more prone to respiratory distress syndrome and transient tachypnea of the newborn. So again, reasons which end up causing separation of mother and baby at birth. Premature birth I've already mentioned, and there's more data coming out now that there are more long-term implications for the children of these women. So these children themselves will have impaired glucose metabolism, metabolic syndrome and obesity later in life or childhood, and some neurodevelopmental issues. So what makes the difference between making this big chubby one on the right and this normal one on the left? Okay, so the absolute key is pre-pregnancy care. It's vital. There is an absolute ton of evidence that it makes a difference to reducing health outcomes for women and these babies, and therefore it makes sense that it actually makes it's cost effective as well. It's cost saving as well. So for both of those reasons, we strongly recommend pre-pregnancy care for both women's health and also for the health system. It's therefore advised that pre-pregnancy care should be involved in all educational programs for women with pregestational diabetes and in the adolescent clinic, so ideally starting when they're teenagers. And we need you guys here for reinforcement, because obviously as obstetricians we don't see these women until they're pregnant, and it's all the education and information they've been given beforehand which is vital for good pre-pregnancy care. The Australasian Diabetes and Pregnancy Society is in the process of updating the guidelines for pre-gestational diabetes, which were last updated in 2005, so they're well overdue. And they come with some really good checklists of what to look at, but they are really extensive. I'd love to show them to you, but it is only in draft stage. It's not fully submitted yet, so I can't quite show you that. But because they are so extensive, I think it's really critical that these women are referred to tertiary care for pre-pregnancy care to ensure that all I's are dotted, T's are crossed before their pregnancy. I'll go over a checklist shortly that will be useful for you, I think, in primary care, but I think one of the keys is that they're referred into tertiary care. And what else makes a difference? So obviously new technologies, there's more women coming to pregnancy on insulin pumps, there's more sensors and continuous glucose monitoring, which I'll talk about shortly, and there's a lot more apps which are useful. And obviously supplements make a difference too. So these women need to be on the higher dose of folic acid, the 5 milligrams, which is opposed to the 0.5 milligram that most women take, and the standard dose of iodine. It's imperative that their medications are reviewed before pregnancy to check that they are appropriate and safe medications for periconception and during pregnancy. And there's a lot of talk around aspirin. There is a randomised trial about to start shortly where they will give 150 milligrams of aspirin to these women starting before 14 weeks and to look at their outcomes of preeclampsia, IUGR, preterm birth and perinatal death. But a lot of people are using it already, particularly in women who might have, other risk factors for preeclampsia. So watch this space when it comes to that. But I suspect it may become part of one of the standard supplements in this group of women. Technologies I touched on. So insulin pumps are becoming more common, and probably because a lot of the type 1s, they get started on that when they're children or adolescents at diagnosis. So women are very used to using them. The aim is obviously to reduce variations in BSLs as they have a background basal rate of insulin, but they also have the facility for bolus doses with meals and activity. They do need frequent site changing, and they need a woman who's motivated, reliable and educated. They are not government funded in the adult setting, but some are covered by private health insurance, but we're certainly seeing more in pregnancy. Along with that, we're seeing more of the sensors or monitors, glucose sensors, continuous glucose monitoring. Now that is the picture at the top. Well, I don't know if you can see it. Oh, whoops. I lost that picture. Anyway, again, that's a little device just attached to the abdomen, which continually monitors the woman's glucose, and it gets sent through to her carer, usually her endocrinologist or diabetes educator. And it comes up looking a little bit like an ECG or a CTG in terms of the glucose levels and the variations and where they should be in target ranges. So it gives really specific and accurate information so that the carers can really fine-tune women's treatment through that time. There was a trial published 3 years ago now in the Lancet, the concept trial, where they tried CGM for women who were trying to conceive during pregnancy and after, and it showed that there were a lot of benefits for the neonates. There were much fewer babies with macrosomia, and there were shorter length of stay admissions for the babies. But there was also advantage for women too. A lot more were stayed in target with their sugar levels, and there was a lot less hyperglycemia. So as well as being good for women and babies, it actually proved to be cost effective. So for that reason, there is Commonwealth funding was introduced on the 1st of March 2019 to cover women who are trying to conceive just with type 1 diabetes. Unfortunately, none of the other diabetes at this stage. At the moment, they need to be referred to an endocrinologist to approve this. They get 6 months initially when they're trying to conceive, and then if they're still not pregnant after 6 months, they'll often be able to get another 6 months approval. Once they are pregnant, they are then have a year of further CGM to take them through the pregnancy and for the first few months afterwards. So seeing a lot more of that, and again, another critical reason why you need to refer women, this group with type 1, to their endocrinologist or their diabetes team early to have this in place to give good outcomes for them. We're also seeing more sensors or sensor flash wands. So again, that picture on the bottom right here, there's little devices just attached to the arm. Women can use a phone or a device just to flash past it, and it'll just give them an instant reading of what their BSL is. They do need to calibrate that a couple of times a day with a finger prick, but it means overall they're doing much less in the way of finger pricking. And this has also just recently been given Commonwealth funding from the 1st of March. So though it's freely available to eligible women with type 1 diabetes. And this is a useful one. This is an app I give all my pre-gestational women. It was actually developed in Scandinavia, but it's been modified by to Australian conditions. It's easy to download, it's free, and it just gives them lots of information about pre-pregnancy planning, what to expect through pregnancy, exercise, all those sorts of things. Good to have on the phone. So I know this page looks busy, but it's kind of the before checklist for these women with pre-gestational diabetes for good pre-pregnancy care. So again, in primary care, contraception is key, that these women should have reliable and effective contraception in place until their diabetes is suitable enough for contraception. I think the LARCs are the best group, so the implants and the IUDs, and again, even in teenagers, trying to get this in place so they're used to the concept and they're in place until they can safely be removed when their HbA1c is appropriate. Once they do wish to conceive, again, if you can check with them that they've got a reliable method of documenting their menstrual or conceptual records, so an app or a diary, just so when they do conceive, we know their cycle length, we know when they conceived. And as I say, these women have to work really hard to maintain an HbA1c under 7%, although ideally 6 to 6.5%. I know I've said it already, but I can't stress strongly enough how important it is to refer these women for health professional review. There's that long checklist of things that need to be done. So referring them to an endocrinologist, diabetes educator, dietitian, and ideally one that's familiar with diabetes and pregnancy. Just like all specialties, we all have interest areas and not all endocrinologists are the same. So again, choosing an endocrinologist that has an interest in pregnancy or already works in a diabetes and pregnancy service, or choosing through the public sector, through choosing a public clinic that is associated with a maternity hospital. They just seem to have a slightly more comprehensive understanding of what they need to do before pregnancy. Similarly, I think it's worth a woman having a check with an obstetrician or gynaecologist familiar with diabetes and pregnancy, just to check everything is as healthy as it could be before she starts trying. As these women trying to conceive, as these women have to work so hard to get their HbA1c under control, we don't want to waste months having missed a problem that's there. So in the private sector, you can refer privately again to an obstetrician gynaecologist who's familiar with diabetes and pregnancy, otherwise to a gynecology clinic at a public hospital, or watch the space. I know at the Women's Hospital shortly they're hoping to introduce a pre-pregnancy care clinic once a month, which will be specifically for these women and will be multidisciplinary, so that hopefully everything will be checked there. So we will let you know if that comes to fruition, but hopefully within the next few months or year. Again, when they're seeing the endocrinal diabetes team, medications will be reviewed. They'll be seeing if they're suitable for CGM. For you in primary care, if you can check that their immunity and their vaccinations are up to date for pregnancy, that they're aware of what preconception supplements they need to take. And again, just keeping at the back of your mind that there may be some recommendations shortly for low-dose aspirin. A really good opportunity too to modify any lifestyle factors such as weight loss, particularly for the type 2 group, stopping smoking, making sure they're exercising, making sure everything's optimal. And again, mental health support, as I say, because these women do have to work really hard to get their control in target, it's often quite an anxious and stressful time for them. And then the time clock is on them to conceive once they are suitable to try. Now, the during checklist. Now, again, these women should be engaged in tertiary care, and their care should be in the tertiary settings. So that if they see you first, then make sure you get an early diagnosis of pregnancy, that they know their menstrual cycle, they know when they miss their period, they get an early diagnosis. We love them to have a good quality first trimester ultrasound around 7 weeks, and ideally transvaginally. Well, it's essential it's transvaginal. And this is not only for accurate dating, because we may need to deliver these women early, but also for viability, because they're more prone to miscarriage. And ensure they're taking the appropriate supplements of the high-dose folic acid and iodine. But then refer them for antenatal and diabetes care early. As soon as you know they're pregnant, just get them on the phone to their usual diabetes carers and engaged, and book them in for antenatal care. Most private obstetricians want to see patients earlier who have got pregestational diabetes. And certainly in the public clinic at the Royal Hospital for Women, we're trying to bring in change where we see them as early as 8 weeks now, so as early as possible. This middle section here is more what they will do at the hospital, and as I say, their care is going to be tertiary, so your engagement with them will probably be more incidental through the pregnancy. Clearly, they'll still need to see you for the standard vaccinations of pertussis and influenza. And if they are seeing you for any other reason, it's just if you can check for us that they are engaged in appropriate care, that they are seeing the teams and the people that they need to be seeing. And again, if we can have your support to encourage breastfeeding with these women, as we know it's going to be harder for them, but if we can put a positive spin on it, then hopefully it gives them more confidence to give that a go. These women too, we do ask them to breast stimulate and breast express from 36 weeks to try and encourage or reduce the delay in lactogenesis too. So it's just aware that that's a normal practice and being supportive of that. And the Dane trial in 2017 showed that it's not dangerous for women from 36 weeks onwards to stimulate and express. They may experience a few cramps and things, but it is not associated with premature birth or labour. And then the after, once it's all over and they've got their baby, these women need, once again, to have good contraception in place by 6 weeks postpartum. Despite our efforts with lactation and breastfeeding, they are more likely to not be fully breastfeeding or not succeed with breastfeeding, and more likely to be fertile. So essential they've got good contraception in place again. Lactation support, as I outlined, and ensuring these women are re-engaged with their usual diabetes care team at that stage. Obviously, in the postnatal milieu of a tired mother and a busy lifestyle, these sorts of things can sometimes be forgotten. And then just making sure that the woman is aware that she needs to plan any pregnancies in future, and that she knows what to do. If she's thinking of another pregnancy, she knows who to approach, and that her contraception remains in place until then. And also a great opportunity to institute lifestyle modifications that might help her long term generally, and also with her diabetes. All right, so moving on to gestational. So this is probably the ones that you see more. And again, just looking at the numbers, so I've just brought back that same graph that I used at the beginning. So you can see in 2008, 4.8% of pregnant women had GDM. And in 2018, it's a growth industry, there's now 13.7%. And I think that's certainly a reflection of what we're all seeing. And again, consistent with the fact that women are having their babies older with larger BMIs, and we're more ethnically diverse. So the GDM risks for mother and baby, they are similar in terms of risk, although usually not as severe as the pregestationals, although again that is dependent on control. If you've got a very poorly controlled gestational diabetic, she may have some of the same risks as a pre-gestational. Conversely, if she has very good control, then she will have, virtually no complications and be similar to the background pregnancy. So preeclampsia and gestational hypertension there, but it's only 1 to 2 times the rate, not more. Again, the increased association with instrumental delivery and perineal trauma and cesareans. If we have macrosomia, they still have the same delay in lactogenesis too. 30% of women who have GDM in a pregnancy will get it in a future pregnancy, and there's a 60% lifetime chance of developing type 2 diabetes for these women, so it's a bit of a warning sign as to what they're prone to later in life. Fetal and neonatal consequences, again, much the same. So if we have macrosomia, operative or instrumental birth, and the birth injury and shoulder dystocia that can be associated with that. These babies too can be polycythemic and have more jaundice. Neonatal hyperinsulinism can again cause the hypoglycemia and also the respiratory distress syndrome and TTN. And again, the same sort of long-term issues of impaired glucose metabolism, obesity. The good news is if they have really good control and no other obstetric risk factors or no a normal sized baby, there's no increase in perinatal mortality rate in this group. So we don't particularly have to deliver them early or interfere with their pregnancy early if they are well controlled. So the before checklist in this group. So again, if you see someone you think she has risk factors for pre-gestational diabetes or impaired glucose tolerance, test her beforehand and see which category she falls into, because that's clearly going to affect her care. Good opportunity to modify any lifestyles such as obesity to reduce the risk of GDM developing in pregnancy. Making sure she's aware of the preconception supplements, which is the standard folic acid dose in this group, and iodine, and ensuring she's up to date with immunity vaccinations, and CSTs, things like that. And again, just making sure she's got a useful or a reliable method of a menstrual conceptual record, so when she conceives, we've got dates right. Now, the during. Now, I'm going to make the assumption with the during that this is through the public sector. Obviously, if she's a private patient, this is all going to be managed through her private obstetrician. But if you are a GP seeing women through the GP Share Care program, then this is more relatable to that. And because I've worked through at the Royal Hospital for Women Diabetes Service, I'm talking about how we work that there. I appreciate as a GP you may be associated with another hospital that has a GP Share Care program, and their recommendations may be slightly different. So first of all, screening appropriately. So, and I think the first thing to know is who not to screen. So clearly, women with pre-gestational diabetes don't need screening. They're just referred straight to the diabetes service. If a woman's had a proven diagnosis of impaired glucose tolerance within a year or two of pregnancy, then she is just treated as having GDM in pregnancy. So she doesn't need testing, she just needs to be referred, and you can refer her straight through the diabetes educator at the Royal Hospital for Women. Women who've had bariatric surgery are usually not able to tolerate the oral glucose tolerance test. So we like you to refer them to the diabetes educator, and we will ask that woman to do a week of BSL testing to see if she has the disease. Beyond that, if a woman has any of the following risk factors, we like her to have a 75-gram 2-hour OGTT, usually early in the second trimester, so just after 13 weeks, 13, 14 weeks. So really, if she's any ethnicity that is not Caucasian, if she's got proven insulin resistance, if she's 40 years of age or over, or if she's on any medications that could interfere with insulin or glucose metabolism, if she's got a periconceptual or initial booking BMI of 30 or greater, if she's had an adverse outcome suggesting undiagnosed GDM such as shoulder dystocia or unexplained stillbirth, or has had a previous large baby over 4.5 kilos. As we outlined before, those women who've had previous GDM have got a 30% risk again, so important we re-screen them. And women with a strong family history, such as a first-degree relative, or actually even ask me about if she's had any sisters with GDM in pregnancy. So if the test is positive, then again, we'd like you to refer her to the diabetes educator, and I've given the email link down there. If that early test is negative, or if the woman is without risk factors, then we like to do a screen on all women at 24 to 28 weeks gestation, and again, of the oral glucose tolerance test. So that is normal screening. Obviously, of recent times have been anything but normal. And so this is the most updated COVID screening that I could find. There's obviously been concern during the more worrying or concerning phase of COVID that social distancing for women was difficult attending pathology collection centres if they needed to sit there for 2.5 hours. So some temporary alternatives were provided and endorsed by ADITS and ADS, although they have very clearly stated that these temporary options are not as sensitive as the oral glucose tolerance test, and that we will potentially miss some women with GDM. It's therefore up to you and your pregnant woman about what she feels comfortable with in terms of screening and what you think her risk is. And I think this chart's quite good in terms of giving us a traffic light approach. So green at the top, meaning the collection centre is able to socially distance appropriately and the contagion risk is low. And for all of that, then we're really looking at usual practice, except perhaps in the postnatal setting, we can still delay her diagnosis a little. If the collection site has limited ability to socially distance or the contagion risk is moderate or high, then again in the early screening rather than the OGTT, we're moving to an HbA1c and random blood glucose with these diagnostic parameters. Again, in that amber zone at the standard time, some women will still have an OGTT, particularly if they have many risk factors for that. But other alternative methods are a fasting blood glucose. If the fasting glucose is 4.6 or less, then she is deemed not to have GDM. If it's 4.7 or 5, it's considered borderline and recommended she proceed to an OGTT, and anything greater than 5 is considered diagnostic. The other group is obviously women who've had GDM in the past and have a glucometer, a working glucometer at home. They can just start doing some BSL testing for a week, and that is another way to check that. The postnatal recommendation is the same in every category. And then in the red category, meaning the collection site's unable to social distance or there's a high contagion risk is high, the early setting is much the same, and the later setting, rather than any OGTTs, it's just doing the fasting glucose. Hopefully in recent weeks, we are feeling we are more in the green and amber zone. So these are just temporary changes depending on comfort level and risk assessment. So back to the during list. So obviously if she's got a positive test, we need you to refer her ideally within 1 week of diagnosis to the diabetes service and ensure she attends that appointment. If you are the doctor that's ordered that test to, you probably need to set up some sort of system of knowing when the woman is having the test and when to look out for the result, as it's really important we don't get any delay between when a positive result is identified and when she gets to the hospital. Clearly at times like over public holidays, it's very easy for 2, 3, 4 weeks to go by, sometimes without those results being reviewed. So ideally, if you've ordered the test, have a system in place to know when she's had the test and when you need to chase the result. At the women's hospital, if a patient is considered diet controlled, meaning she is compliant and her sugar levels are within the normal range with diet and exercise modification only, she is still part of the GP shared care program between you and the midwife, and you will be doing her antenatal visits. As well as her standard antenatal visit, we also like you to weigh her at every visit, and we need you to check her diabetes compliance. So we need you to ask her how she's going with her diabetes, check her diary, check her glucometer, check she's actually performing the tests and recording them. The Women's Hospital does have a system where the diabetes educator asks women to email their sugars every 2 weeks, and the diabetes educator likes to see them every 4 weeks, even with diet control. But sometimes for women who are not compliant, this gets overlooked. And so if they're seeing you for incidental visits, we really need you to check on that yourself. If you are concerned about her control, then please email or phone the diabetes educator, get onto that promptly, as she may need to come to the diabetes clinic for further surveillance. As this group's considered relatively low risk, they don't need any extra tests, so no extra ultrasounds or anything for her diabetes, and they don't need earlier delivery. However, they do get referred to the diabetes team or the obstetric team at the Women's Hospital when they commence insulin or metformin, if they're non-compliant or don't have good control, or if they have any other significant risk factors. So once they have these criteria, they are no longer part of the GP shared care program, and they are managed solely at the hospital, and we will be organising all the extra investigations that are needed and make a decision about when and how is the appropriate delivery time for her. Obviously, the woman will still see you for the standard vaccinations during pregnancy, and again, if we can have your support with support in terms of benefits of breastfeeding for these women. In particular, the 30-year Cardia study showed, over here. So this is a study which over 30 years, very well done. Along the bottom axis is how long women breastfed for, and on the vertical axis is their chance of developing type 2 diabetes, and the pale blue is the women who'd had GDM. So as you can see, if they didn't breastfeed at all, they have a much higher chance of developing GDM over 30 years, and that is lower as they've breastfed. Obviously, the all group looks higher because it's all of them together, but the longer they breastfeed, the more protective that is for them getting type 2 diabetes long term. And then the after checklist. So just as we said, so just lactation support would be great. Ensure a contraception plan is in place for women who you think might be more likely to have ongoing diabetes outside of pregnancy, or someone who is at high risk of developing type 2. The NDSS advise all women with GDM have a 75-gram OGTT, preferably 6 to 12 weeks postpartum, although as we've outlined in these current COVID-19 times, that's more 6 to 12 months postpartum. So at the moment, I think only about 50% of women tend to have that done, probably because they're very busy and tired postpartum. So if you can ensure that that's been addressed. The NDSS also advises women to have regular annual surveillance for the development of type 2 diabetes, either with an OGTT or an HbA1c every year. So we really need you involved for that. And advise women to have a check with you if they're ever planning another pregnancy before pregnancy occurs, just again to go over those things we were looking at in the before checklist. And a great opportunity for lifestyle modifications. All right, so I think that's enough of me talking. I'm very happy to answer any questions if you have any.
Hi, Dr. Hawke. So we have a few questions that have come through that I'm keen to go through. So the first one is, how do you manage women who have persistent glycosuria but 28/40 oral glucose tolerance testing is normal? Is there an impact if there is an FH of diabetes, such as high risk?
Yeah, glycosuria is not a useful test in pregnancy. The renal threshold for glucose is much lower in pregnancy. So if you get glycosuria in the urine, it really just tells you what she ate 2 hours ago, but it's not at all diagnostic for GDM. So we don't use that at all for GDM prediction in pregnancy.
Great. So the next question is, for preconception care for women with diabetes, which tertiary clinic do we refer to? Do you mean diabetic clinic or obstetric medicine?
Yeah, so well, yes, I think I think if you're in the private sector, I would refer to one of the obstetric physicians that is familiar with diabetes. So obviously at Prince of Wales Private and the Royal Hospital for Women, we have Professor Sandra Lowe, Dr. Amanda Beach, and Dr. Sumay Lau, who are all involved with the diabetes service at the Royal Hospital for Women, so that you can see them privately. Through the public sector, they would probably need to go to the Diabetes Centre at Prince of Wales Hospital, and Dr. Anne Poynton is the endocrinologist who usually deals with the type 1 diabetics. It's Dr. Milner and Dr. Detchinsky, I think, usually deal with the type 2 diabetics. But as I say, we're hoping to get a pre-pregnancy care clinic up and running at the Royal, where those women could actually come to the Royal and do that. So that's not working at the moment, but that's where we're at from that point of view.
Okay, the next question is, can GPs start aspirin in patients who are pre-gestational diabetic who become pregnant?
Look, of course they can start it, but I think it was just probably to give you the information that it is not categorical yet, that those women should have it in pregnancy. There's a lot of research going on in that space, and it's quite possible in the future that they could. But look, you know, I think if I've got someone who is older, overweight, already has gestational essential hypertension, or has a strong family history of hypertension, and she's a pre-gestational diabetic, I would probably start that on her at the moment. But again, you can probably leave that to the obstetrician or the obstetric clinic to start that, you know, take their advice on that.
The next question is, if diet controlled, what are the blood sugar targets for the women? This will help to understand when control is not good.
Yeah, that's right. So usually the women know, they're told. But standardly their fasting in the morning should be under 5. Depending on whether they're doing 1 or 2 hour post-testing, because that depends a little bit on what their GTT result is. But the 1 hour is usually under 8.8, I think, and the 2 hour, I think, usually under 7.8. But the woman herself should know. We have asked the diabetes team to write it at the top of their book, but I think they sometimes get very busy and forget to do that. But those are essentially the targets. So under 5 for the fasting, and under 7.8 or 8 for meals, depending on whether they're doing 1 or 2 hour testing.
The next question is, what is the fasting BSL cutoff in the first trimester?
Now, first trimester is tricky because of the hormone changes of pregnancy. Sometimes a fasting BSL can be up to 6 and be normal. So that's why we have moved early testing out of the first trimester, because we were getting some false positives with women getting a raised fasting in the first trimester, but the other 2 readings being normal. And then in fact, realizing with time that was a false positive. So up to 6 is actually considered normal in the first trimester.
Great. The next question is, if not tolerating oral GTT, i.e. vomiting, syncope, what are the cutoff BSL marker? Is that similar?
If they're not tolerant, if they can't physically perform an OGTT because of vomiting, then again, we like you to contact the diabetes educator, because those women do fulfill criteria for being able to do a week of BSL testing. So if you refer them to the diabetes educator at the women's hospital, she will get them in and teach them how to test their sugars for a week. So we think that's a more comprehensive way of looking at that.
The next question is, annual screening post-diagnosis of GDM, glycated hemoglobin, is much easier to do. Is it acceptable always, or should OGTT be done every 2 or 3 years?
Yeah, look, I think the OGTT is the gold standard, so it is the better test, and I think you just have to make that's a bit of a judgment call just about what the woman would tolerate. Obviously, some testing is better than nothing, so an HbA1c is better than nothing. But I think we'd usually say alternate, 1 year in OGTT, 1 year in HbA1c, but I think you have to make that judgment call between you and your patient.
The next question is, what is the best routine testing preconception for women with no risks, i.e. HbA1c or just FBSL?
No risks. probably just, I don't know if I'd even do it if they had no risks. Because really you're looking for an HbA1c pre-pregnancy is really just going to pick up type 2 diabetes, so it's not going to pick up any lesser degree of hypoglycemia. So I think if you think she's got type 2, you probably should be doing a more comprehensive test than that. But I wouldn't routinely screen beforehand if the woman has no risk factors.
Great, and the last question we have is, does breastfeeding affect sugars for women with pre-gestational diabetes?
It seems to help modulate their sugars afterwards, so they seem to have better glycemic control if they're breastfeeding afterwards.
Okay, we do have one last question that's just come in. Postpartum, if using annual HbA1c, what is the cutoff level for concern?
What's the type 2 level? I think it's, I'm so used to the pregnancy levels, I can't think of it outside, but I think 6.5, 6.5, 7. I'll get back to you on that one.
Perfect. Thank you so much, Dr. Hawke, for presenting. It's been really great. We did have a couple of questions come through just about the presentation overall, whether it will be recorded. It will be recorded and put on the video library of the PHN to be available to watch afterwards if you wanted to share it with any of your colleagues. And someone else asked if there will be copies of the lecture notes or the slides emailed afterwards. So as long as the speakers consent, we will attach that to the email with your certificate as well. Fantastic. So thank you, Dr. Hawke.
All right.
Our next speaker
Would you
is...
like to unclick everything?
Yes, that would be great. So our next speaker is Dr. Rahul Sen. Dr. Sen, you there?
Yeah, I'm here. Can you hear me?
Yep, who's speaking on advanced maternal age and pregnancy. So yep, we have your screen up and we can see and hear you. Perfect.
Hi. Well, thank you very much for inviting me to speak. When this was first designed some month ago, we were looking at an exponential rise in COVID cases. So I tacked on a little bit about management of high-risk pregnancy in a COVID setting, including advanced maternal age, which I will have left at the end, although the cases now seem to be much more stable. So I'm an obstetrician at Prince of Wales Private and the Royal Hospital for Women. My rooms are in Edgecliff, the city, and Randwick, although during coronavirus I'm only in Edgecliff, and that's my website. I sent through some learning objectives talking about different pregnancy outcomes associated with advanced maternal age and pregnancy, some strategies for mitigating the risk, and then some strategies for mitigating risks associated with COVID-19 and high-risk pregnancies, including advanced maternal age. Thinking briefly about success. So success at 4 is not peeing in your pants. At 12 is having friends. At 16, having a driver's license. At 20 is going all the way. At 35, it's having money. 50 is having money. 60 is going all the way. 70 is having a driver's license. 75 is having friends. And 80 is back to not peeing in your pants. So age matters. In terms of pregnancy, age matters. Risk in terms of age is a continuum. We have data on over 35, over 40, but in actual fact, it's a spectrum of risk, and any cutoff is slightly arbitrary. The same could be said about gestational maturity. So we often talk of term as over 37 weeks, but in actual fact, from 39 weeks to 41 weeks is probably the optimal time for for all babies to be born, subject to other risk factors. We do know that around the world, including in New South Wales, and in particular in the eastern suburbs of Sydney, the proportion of older women in pregnancy is increasing. So it was around 4.8%, increasing to 7.6% in 2016. That trend in the UK is even more marked. And in the 20 years from 87 to 2007, the proportion of maternity patients aged over 35 increased from 8% to 20%, and aged over 40 increased from 1.2% 2 to 3.6%, so effectively tripled. If you look at these, this curve, you can see that fertility declines steadily, particularly from age 35 and dramatically from 40. And on the other side of the curve, other side of the coin, miscarriage rate increases steadily from age 35 and then very steeply from 40. Although I'm not principally talking about fertility, as I mentioned, it falls steadily after 35. Kirsty Allsop, you'll know from location, referred to it as falling off a cliff, for which she got into a bit of trouble, but she's absolutely right, although the cliff really is after 40. I did receive a question about the role of AMH testing in this group of women. I must say, I think it's of limited value in women of this age. Maybe AMH and natural follicle count in younger women who want to delay childbearing and confirm that they can. But even then, I would urge caution, because AMH levels are not absolutely reliable, and they only really answer the question of ovarian reserve, not really fertility. There may be unexplained fertility, tubal obstruction, male factor, etc. So I think if you're in this age group, I wouldn't do anything to delay fertility. Then in early pregnancy, as I've mentioned before, got a very high and rising miscarriage. Many people are surprised to hear that miscarriage rate at age 40 is around 40, so an odds ratio of around over 2. There's also a higher risk of aneuploidy, which everyone's familiar with. It's roughly 1%, a little bit higher actually at the age of 40, compared with about 1 in 1,000 at age 30. So that 10-year difference makes a big difference to aneuploidy rate, especially Down syndrome. And then broadly speaking, the other risks associated with advanced maternal age are twin pregnancy, placenta previa, gestational diabetes, around a doubling in risk, preeclampsia and gestational hypertension. You see, I've starred some of the associations that are a bit more controversial. There have been about 4 or 5 big studies that have largely provided us with the data. There's a very clear increase in risk of preeclampsia. There may be a risk of gestational hypertension. In any case, as a condition, that's not usually such of a concern for us. It's usually later and milder. It's the preeclampsia risk that we're concerned about, and that has certainly increased. Odds ratio about 1.5. Risk of preterm birth, partly iatrogenic, partly spontaneous, again about 1.5. Here's some controversy. Some studies showing, most studies showing small for gestational age or growth restriction, a few showing large for gestational age. Again, large for gestational age, not such a big concern in terms of management by and large. Small for gestational age or growth restriction, sometimes difficult to tease out, but associated with an increased risk of stillbirth. Late stillbirth with a moderate increase in risk, odds ratio of 1.4. Very significant increase in risk of Cesarean section, both elective and emergency. And then a smattering of other things: malpresentation, prolonged labour, postpartum hemorrhage and abruption. I should add that the findings between the different studies haven't been totally consistent, but the trend is by and large there. This is from one of the big studies, Colours, one of the most recent studies, and you can see the trends: very large increase in risk of miscarriage, increase in risk of preeclampsia, and small for gestational age, largely sort of exponential risk as maternal age increases, and then a linear increase for diabetes and large for gestational age. So now thinking about some strategies to mitigate those risks. So for miscarriage and twin pregnancy, obviously we can't prevent those, but we can diagnose them promptly. Wendy mentioned the importance of a dating scan. It's interesting that it still isn't government policy that all women in pregnancy should have a dating scan, but I firmly believe that they should. We need to know that there's an ongoing pregnancy. We need to know that they don't have twins, etc. So 8 to 10 weeks is an ideal time for all. I think all women should have a dating scan. We can detect aneuploidy. So for many years we've had the first trimester screen, so a combination of serum screening done at sort of 10, 11 weeks and a nuchal translucency scan at 12 to 13 weeks. Those two in combination will detect Down syndrome approximately 80 to 85% of the time. Now with the non-invasive prenatal test, they've got over 99% sensitivity. The two main players are probably the Harmony test, which you're more familiar with, which is an American-based test, First Step test, which is an Australian test from Victoria, and both of those will give us very reliable information about Down syndrome in particular, but also trisomy 13 and 18, and you can determine the fetal gender with, again, over 99% reliability. Should add, of course, that NIPT is not covered by Medicare. It's rarely covered by the hospital. There are some exceptional circumstances for public patients, but they are. The out-of-pocket cost is about $450 to $500, depending on which one you did. I received another question by email in advance, which was NT scanning for preeclampsia screening. So the NT scan itself is not really of any help. With a good history and serial measurement of blood pressure at booking, you can actually identify around 60 to 65% of women at risk of developing hypertensive disease in pregnancy. Not necessarily preeclampsia, not necessarily early onset, but at least you can identify women at risk and triage their model of care. The new factors, the angiogenic factors, especially PLGF, can take this to up to sort of 75 to 80%, so it will add a little bit. We don't know yet that intervention makes a difference, but we know in other settings that that intervention, so for women who've had severe early onset preeclampsia, we know that low-dose aspirin and calcium will reduce the risk of recurrence, and the intervention studies are on their way for these, and also timing of delivery. It's a Phoenix study on its way. Placenta previa, of course, you cannot prevent, but can diagnose. I should add that the majority of what's considered to be low-lying placentas at the morphology scan are well clear of the internal os. The placenta can so-called move by up to a centimetre a week, often referred to as placental migration. It probably actually remains attached to where it is, and that's a function of the lower segment elongating and pushing the part with placentas attached further out of the way. For most women who don't have bleeding during pregnancy, who have a low-lying placenta, they only need a single scan at 36 weeks to confirm where the placenta is in relation to the cervix, and that should be a good quality transvaginal ultrasound performed in a centre that specialises in pregnancy ultrasound. Of course, those women remain at risk of postpartum hemorrhage because the lower segment doesn't contract as well as the upper segment, so we should do everything we can to maintain good haemoglobin during the pregnancy and monitor their iron stores. The new cutoff for the last 2 years has been 30, not 15, and for women borderline result or who don't tolerate iron tablets, or who don't get a response to iron tablets, I'd have a low threshold for giving 1 gram Ferinject infusion during the pregnancy. And then advanced maternal age is associated with an increased risk of gestational diabetes. Wendy's already talked about doing the glucose tolerance test. The 75 gram load is usually given in the form of glucola, which is approximately the equivalent to sculling 2 cans of Coke within 10 minutes, which some women find very difficult to do. If they have other risk factors, you might consider doing an early GCT at 14 weeks, and then again at 27 weeks if it's normal. Some women decline the glucola drink, in which case you could consider some of the options that Wendy talked about during COVID, which I'm going to come back to later on. And then hypertensive disorders, again, the one we're worried about is preeclampsia. We can do early onset preeclampsia screening, serial blood pressure at booking, PLGF, family history. Those 3 will give you will pick up more than 60% of women at risk of preeclampsia in pregnancy. Other thing that would be suspicious are the lack of a physiological fall. So most women, you see a blood pressure drop at around 20 weeks in mid-trimester, and if you fail to see that, that is sometimes a concern. One thing I should say is that with increasing numbers of women with advanced maternal age, a number are going overseas and having donor egg pregnancy, particularly in America, South Africa, Spain, etc. Obviously not in the current climate. But those women have a very significant increase in risk of preeclampsia, not necessarily early onset preeclampsia, but preeclampsia as much as 30%. And so any woman with a donor egg pregnancy, I would put on low-dose aspirin and calcium. So low-dose aspirin is 150 milligrams. It should be taken at night. Calcium is 1.2 grams, so 2 tablets of caltrate. Don't take it with magnesium or iron, because it reduces absorption. Preterm birth can be iatrogenic or spontaneous. The relative increase in risk is actually small. It's largely unpredictable. Biggest predictor is previous preterm birth, which doesn't help us, obviously, for the nullips. It is increased with a cervical length under 2.5 centimeters at the morphology scan, and in that setting, with a choice between progesterone pessaries and cervical cerclage. The two seem equivalent in effectiveness, and progesterone pessaries is much better tolerated and has a lower risk of preterm pre-labor rupture of membranes. Large for gestational age and small for gestational age, again, the relative risk is quite small. If you're concerned about any woman, I'd get serial growth scans, for example, 32 and 36 weeks, or although other regimes can be helpful. What's particularly important is a good amniotic fluid volume and good fetal movements, and we now have a number of apps and other things to help women be part of that process. Perhaps one of the concerns we're most concerned about with advanced maternal age is risk of late stillbirth. And I actually think that stillbirth should be discussed as a thing for all pregnant women, and so they understand why we're making many of the recommendations that we're doing, because a lot of them are about minimizing stillbirth risk. In a sense, you're balancing the ongoing benefits of prolonging gestation until 39 to 41 weeks with a very small but very slowly increasing risk of stillbirth after about 38 weeks. Benefits of prolonging gestation are clear, both short-term and long-term. Short-term, they're mainly reduced respiratory distress, reduced transient tachypnea, reduced jaundice, they feed better, and all long-term. So there's quite good longitudinal cohort data to show better school performance, a higher IQ, fewer neurobehavioral problems in babies born later. And it also allows women to go into spontaneous labour. However, on the downside, the risks of stillbirth are definitely there, and it's very individual as to how women interpret that risk and perceive that risk and reacts to that risk, but as long as it's discussed. So the benefits of an induced labour are reduced risk of late stillbirth. We know from the ARRIVE trial that women were induced from 39 weeks onwards. There were high rates of maternal satisfaction. There were actually lower rates of caesarean section, and that is contrary to the conventional teaching, which always used to be that induction of labour prior to 41 weeks increased the caesarean section rate. We know that that's not true. We had a suspicion that wasn't true. There's a number of studies looking at induction for other reasons, diabetes, high blood pressure, etc., had shown it wasn't true. But now in a low risk population, the ARRIVE trial told us that for all women, inducing labour at 39 weeks reduces the caesarean section rate. So I think we can say to women confidently, inducing at 39 weeks does not increase the Caesar rate. That, of course, doesn't translate into that all women should be induced. It's simply we don't need to be scared of inducing. We don't need to advise them not to induce. We need to discuss it as an option that they have. We do know that women who are induced have much higher rates of epidural. So another big risk with advanced maternal age is caesarean section. And again, women are surprised to hear that their risk of needing a caesarean section at age 40 is approximately 50%. We still don't know exactly why that is, but there is a physiologically demonstrable reduction in myometrial contractility. And somebody described it as being labours like an elite athletic event, and we know that by and large elite athletes do best in their 20s, not so well in their 40s, and labour may be the same. For that reason, I think it is reasonable to offer women age 40 and over an elective caesarean section or planned vaginal birth, whatever their preference, as long as they understand that they've got an approximately 50% of needing a caesarean section. Generally, if we're going to do a caesarean section, we would do it at 39 weeks, similar to when we would induce them. We do know that caesarean section has its downside, so it's still a major procedure. Even though it's very safe, it may impact on feeding. It is likely to affect the fetal microbiome, and we still don't know exactly what that means, but more information is coming out year by year. It does appear to have some impact on the fetal or neonatal immune and autoimmune condition that may play out in later life. So I might touch briefly on the pandemic. Of course, this was designed at a time when the pandemic was rife and cases were increasing exponentially. The latest figures show, although globally it's a major problem, 3.5 million cases, 250,000 deaths, but Australia very, very stable, about around 6,800 cases, 96 deaths. Majority of our cases came from USA, Europe and the cruise ships. We've had very, very widespread testing, over 660,000 tests, around 1% positivity. I think we've been very lucky, but there may be a second wave, so we're certainly not seeing what we had feared that we might see, was the hospital overrun and resources stretched. But we still have a pool of COVID positive people within the country, and there is the potential for that to get out of control, as it has, say, in Singapore and Japan. So there may be a second wave, so it would be worthwhile being prepared just in case. We've been doing a lot of preparations, a lot of policy work, a lot of changes to theatres, to clinics, etc. Some restrictions in the hospital. So you're probably aware that in both the Women's Hospital and Prince of Wales Private, there are no visitor policy. At Prince of Wales Private, until last weekend, partners could not come and go as they wished. Once they come in for birth, they stayed until the woman herself was discharged. As of last weekend, that restriction's been lifted. But a lot of work has gone into preparation for COVID, and we're ready. There's a video link there. So these slides, I think, are going to be made available to anyone. There's a video link that I'm not going to play, just showing a rehearsal emergency COVID cesarean section that we did. And then again, this is probably something that you're already doing now routinely, but at the time these strategies were new. How can we respond to that but still give care to women? So the conventional approach to antenatal care was 4 weekly visits to 28 weeks, then 2 weekly to 36 weeks, then weekly till birth. And the suggestion was that we could easily reduce that total number of visits by 1, 2, or even 3. So we've got a 5 weekly visits till 30 weeks, then 3 weekly to 36 weeks, then weekly till birth. We could do a combination of telehealth. So most of the consultations are discussions, relatively short amount of actual clinical assessment, weight, blood pressure, abdominal palpation, and then some sort of fetal assessment, Doppler or ultrasound, which can usually take less than 5 minutes. The discussion can be done by telehealth combined with a small, short face-to-face visit, usually with nobody else presenting, so no partners, no children, wearing masks and social distancing. So I think that enabled us to come up with a strategy for offering women ongoing care while minimising risk. Wendy's already mentioned the modified diabetes screening proposal, and this is one of the models around the country, is to do a fasting glucose test. This was attractive when women had a great fear of going into pathology collection centres where there are lots of other women sitting there and staying for 2.5 hours. Probably in the current environment, we're starting to go back to the feeling that it's actually quite safe to do that. But again, that may change in the future, and this could be a strategy to do a single fasting glucose test. If the results 4.6 or less, then to consider them as not having gestational diabetes. As Wendy said, that will miss a small number of women. If the result's over 5.1, as it was with the 3 tests, then that's considered just gestational diabetes and treated accordingly. And then the sort of the in-betweeners, the 4.7 to 5, for those women, you'd have to choose between doing a full glucose tolerance test. Again, part of this was driven by women not wanting to go to collection centres. So those women, by and large, would be happy to do home blood glucose monitoring. But that is expensive and it's labour intensive, and it's certainly not possible to do that on a very wide scale. But for a small number of women, which it is a relatively small number in that group. The other point that I would make is in light of a case that we had at the Royal that I was involved with, where we actually did an emergency COVID cesarean section for a woman with a fever of unknown origin. We suspected she probably had a urinary tract infection, but we didn't have a definite diagnosis, and her swab results went back and she needed an emergency Caesar on fetal grounds. So we went ahead and did the full PPE Caesar, which was obviously for us a good training exercise, but for the woman not a great experience at all. And in hindsight, I think one of the teachings for us, or the learning points for us, was that if we had been super vigilant and got the urinary tract infection under control at an earlier stage in the pregnancy, and there may have been an opportunity to do that earlier, she'd have had a diagnosis, she'd have had treatment, she'd never have been suspected of COVID and wouldn't have ended up with the emergency COVID Caesar that she had. And then a few other strategies. So a lot of people are working from home. We've talked about trying to minimize risk within the home. So self-isolating from 37 weeks, so children in childcare or partner working from home, considering induction of labour, so it's planned to fit in with that time frame when if it helps. And the other thing, of course, is that we found not all hospitals were the same. So some hospitals had restrictions that were very, very difficult for couples, and the hospital I mainly work at, Prince of Wales Private Hospital, was quite strict on partner restrictions, and that was challenging because other hospitals didn't have that same restriction. And so for couples who, say, didn't have any family and had other children, it made life very, very difficult if the partner wasn't allowed to come and go in the hospital. And so if we're back in that situation, then and that causes a real problem, then you can consider other options, including other hospitals. Now, this is a bit of fun. I've got a glossary of terms we learnt from coronavirus. I've included that in the presentation for you to read through. My favourites, elephant in the Zoom. So, in summary, talked a little bit about advanced maternal age. It's a spectrum. It carries risks of a range of adverse pregnancy outcomes, many of which, not all of which, but many of which can be mitigated with fairly simple strategies. I think dating scan is essential for all women. Stillbirth risk is something that should be discussed as a routine for women. It's very confronting to talk about stillbirth, but as soon as you open that discussion and women realise that it's a standard part of every pregnancy discussion, and it's normal to discuss, and it explains why we're doing what we're doing, women certainly do accept it. And moreover, women who've had very bad outcomes, particularly stillbirth, feel very angry that stillbirth was never discussed with them, and we owe it to them to make sure we've had an honest discussion. COVID cases are low and decreasing, but there may be a second wave. And again, simple strategies may mitigate that risk if we see the second wave rise again. I've got some references here. So are there any questions?
Great, thank you, Dr. Sen. So the first question is a patient example from a GP. So it said, what would be the success rate of an IUI versus IVF in a 45-year-old female with normal period, normal hycosis, present follicles on ultrasound, AMH low, but as per her age, and who will be using a sperm donor? She is otherwise healthy and not on any medications, non-smoker, drinks rarely, and has no PCOS.
Did you say 45?
That's right.
Well, I'm an obstetrician, not a fertility specialist. We've got a fertility specialist on our panel. He's probably better placed to answer that question. But really, to the best of my knowledge, once you're over 43, IVF is really no help. IUI may offer a glimmer, but I don't think doing IVF is going to help you at all. IUI may help you. Maybe Justin can answer that better than me. IUI is probably worth a try. I think by the time you're getting to that age, if you've tried IUI and you're not successful, I think you're probably looking at egg donor IVF.
Great. So the next question is, what are angiogenic factors in predicting preeclampsia?
So angiogenic factors, so the two main ones that we're aware of are SFLT and PLGF. PLGF is the one that is used in early testing and prediction for preeclampsia at a later stage of the pregnancy. It may be later in the pregnancy that SFLT or an SFLT PLGF ratio gives us good information about women who are at risk of developing preeclampsia within the next month or couple of months. So for later in the pregnancy, it may be a better test. At the moment, it's a very expensive test. It's available only in the hospital. So I think in the primary care setting, the only test that's really relevant is PLGF, which in association with the early pregnancy screening will help predict. As I said, it it takes your risk assessment of preeclampsia from about 60%, 65%, which you can do on history and booking blood pressure alone, to maybe 75, 80%.
So about the PLGF, someone has asked when the test should be done, if it's okay to do it the 10 to 13 week test.
Yeah, so PLGF is commonly performed around 10 to 13 weeks. I'm not sure what the absolute earliest you can do it. So usually I'd do it at 11 weeks.
Great. And the next question is, should women over 35 be on 5 milligrams folic acid instead of the 500 micrograms?
There's no evidence for 5 milligrams of folic acid in any population, even the diabetic population, as it's commonly recommended, but there isn't good evidence to say that 5 milligrams should be used for anybody except women who have deficiency of folate metabolism or who are on anticonvulsants, where we know or who've had a previous neural tube or defect or some other spinal problem. But actually no other women are required to be on 5 milligrams. Having said that, the folate is harmless. It's benign. Whatever you don't need, you pee off. So you're not gonna cause any harm by giving everybody 5 milligrams.
Great. And the last question is, why is there an increase in twins in advanced maternal age?
I don't know the answer to that. Well, I think it simply relates to the biochemical complexity of conception, and that as tissues and as cells age, there's a greater propensity for error, and that's why there's a higher rate of a whole range of altered things. Now, twins obviously isn't necessary, isn't an abnormality, but it's a variation. So some of those are critical, such as chromosome abnormalities. Some of those are lethal. Some of those are minor, and that probably explains twins.
Great. Well, thank you so much, Dr. Sen. That was all the questions that came through. Thank you for your time. Yep. So our next speaker tonight is Dr. Justin Tucker, who will be speaking on donor conception for Sydney patients. So Dr. Tucker, I'll make you the presenter now, and you should be able to share your screen now.
Hey. Brilliant. I'm just going to find, here it is. Fantastic. Hello, everybody. Thank you very much for having me. My name is Justin. I'm an obstetrician at the Prince of Wales Private Hospital. I'm also a fertility specialist with an affiliation with Monash IVF. And today I'm going to talk about something that's not so much known, I don't think, and increasingly important, and that's access to donor gametes, so donor eggs and donor sperm. Here, particularly in New South Wales, because legislation is different in each state, and the good news is that New South Wales is actually one of the best ones. Great. So learning objectives, I thought we could go through them. The first one is what options in New South Wales do our patients have? So I think good treatment means exploring all options. I mean, that's one of the foundations of being a doctor, I find, is that trying to match a patient with their treatment to their different needs, values, and priorities is kind of the cornerstone of what we're going to do. So knowing options and knowing what they're out there and exploring them with the patient is super duper important. There are some hoops that we have to jump through because of the legislation, but that is a well-worn path. We've got a great team, I do, that's used to supporting patients in that process, and so it's relatively easily overcome. Patient support and counselling requirements, super important. We want these patients to be protected. It's not uncommon to say that patients are quite desperate when they're using donor eggs and donor sperm. Yeah, they're in a vulnerable position, and we don't want that to translate into corner cutting or being super financially vulnerable, because those things have long-term implications, and it's important, I feel, to protect our patients against that and to keep everything in check. Treatment options available when using donor sperm, that varies because we've got IUI and IVF. With donor eggs, we essentially have to use IVF. And cost, super important. I think all of my patients must think that I'm so tight because I'm forever banging on about cost, but it is important. I never want my patients to feel like I do when I take my car to the mechanic. That is not my field. And I don't know what they're going to do. I don't know what the alternatives were. I don't know why they're doing it, and I don't know how much it's going to cost me, and I always feel vulnerable, and the whole thing's shady. It's probably not shady, but because I'm not informed about those sort of things, I feel like it is. And so with adequate financial information, then patients don't need to feel like that. One of the other objectives that I wanted to get out of today, and when we sort of first set this up, it was going to be in person, was for me to be able to get to know you and maybe you to get to know me a little bit. I totally realized that when you refer to somebody, and I do that a lot in my job as well, you feel very responsible for that. And to be able to pair a patient with a doctor on lots of levels is important and a big responsibility. And that's kind of can be hard to do if you don't know much about the doctor. So I thought maybe I could talk a little bit about me. So that's me on my Photoshop version. This is me when I've been working all the day and hungry. You can see the difference. I grew up in Melbourne, grey as it is. I then went to Sydney Uni. Definitely don't come from a medical family, but I'm very glad that I chose medicine. I like my job a lot. Went back to Melbourne and did all my specialty training there, and but I always knew I wanted to come back to Sydney to open private practice, and that's what I've done. This is my main office in the city. I like interiors, and I'm very lucky to have an office that was built in 1929. I spent a lot of time and effort and money actually renovating my office, and that's been I don't know, give me about 3 million breakdowns, but it's all done. I love being able to curate an experience for patients in the private system. That's the biggest difference between public and private, and it's brilliant. I've also got locations in Bondi Junction, beautiful Bondi, and we also go to Rozelle once a week. I couldn't find a picture that was particularly fitting or obvious to be Rozelle, and I can never seem to do a PowerPoint presentation without including a diva. So this is Rose from the Golden Girls and Elle, who together make Rozelle. So if we move on to objective 1, working out or discussing options for patients in New South Wales to access donor sperm and eggs. First, I thought we'd talk about maybe who is accessing this, who needs access to donor gametes. A large proportion of my work is made up of same-sex couples. So we have a team here that is very supportive of making families like that. And I have to say that Prince of Wales Private, which is where often a lot of my same-sex couples deliver their babies, because I'm an obstetrician as well, so I often continue the work from fertility to obstetrics, or they just come and see me once they've already conceived. Prince of Wales Private is brilliant in looking after the special needs of my same-sex couples. The other people that are becoming increasingly in need of donor sperm is single women. And I think it's important. I always speak to them about the benefits of being a single parent. It's not you've failed in life and haven't met a partner. I mean, I'm Generation Y. I get the pressures that we have. We need $1 million to buy an apartment. We need a degree to do anything. All that takes time. The world is a small place, and we're increasingly independent. And a product of all that is an increasing number of women who want to start a family as a single woman. Single men are also doing it too, and need of donor egg, but we can talk more about that a little bit later on. And the benefits of being a single parent, of course, are that you get to be judge, jury, and executioner of all the decisions in the child's life up to a certain age. And you don't have to consult with somebody else. You don't have to have somebody else who can then leave and take half the money. Can you tell a child of a broken home? So plenty of advantages. And, again, curating a practice that is supportive of that. I mean, my obstetric practice is set up in a way where we've got a private midwife who can act as an extra support, and we always support people to come along to the appointments as well, no matter who they are. But I think it's also important to point out that heterosexual people are still, or couples are still absolutely in need of donor gametes. Azoospermia and making no sperm is quite common, and these couples need access to donor sperm, and they need choice. Often they want to match the donor sperm to the phenotype of the male partner, and therefore choice is important, and the ability to offer that choice is important as a practitioner. Women, so there's plenty of ladies who undergo premature ovarian insufficiency, we call it now, rather than failure. So menopause early, or have maybe left their run a little bit late and are of advanced age and need a donor egg. Okay, so that's right. So before I go to the next slide, I just wanted to talk about now the options we have to offer patients who need donor eggs and donor sperm in this state. The first one I want to talk about is eggs. So eggs are much harder to access and much more expensive to access than sperm. But options are options, and I think it's important that all patients know which options they have. This is one that we can offer here in New South Wales for eggs. It's called the World Egg Bank, and it's not one that I offer very often, and there's a few reasons for that. I don't think it's good value, mainly to the point. But it's US based, mainly in Arizona. When you buy these eggs, you can either buy them from a frozen pool that is matched to a donor that you've chosen, or some donors will have to be stimulated with the purpose of you having the eggs. The thing is that with the World Egg Bank, they don't give you all the eggs. So you might go through an inventory with information. It's not that much information compared to some of the other options in sperm. They'll then stimulate that patient, but you'll only get 7 eggs. Now, there's no Blastoise Guarantee, which is an important thing to consider, and another reason why I don't think this is a particularly good option compared to some other options that are out there. Blastoise is the most advanced stage we can get an embryo to before transfer. To get to Blastoise stage, it means that embryo has survived numerous important steps and proven its worth of being transferred and to have a decent chance of success. It's quite expensive at almost $20,000 US. Remember, that's also that doesn't include an IVF cycle, which would happen here in New South Wales and would be another approximately $5,500. It is Medicare eligible. If the woman needs an egg, then she's got subfertility. I'm just looking at my notes if there's anything else I want to say. So the other thing that they only do guarantee is a 60% thaw rate. So out of those 7 eggs that are frozen, if you get 4 eggs that survive that, they say that's fine. And I'm telling you that 4 eggs making, doesn't give you that great a chance of getting a baby. Yeah, the donors are all in their 20s, which makes a big difference. So my opinion, and I guess this is being recorded, and I should be careful, but this is a little bit like an egg farm. and I've got some issues with that. So if we look at other options, so this is onshore as well, and maybe I need to clarify the World Egg Bank. Those eggs get shipped here, and it's sort of, you know, it's all processed in Australia. Egg Donation Australia is an online-based resource. It's not as regulated. It's essentially free. So it's kind of an organisation that tries to match people that are willing to donate their eggs to people that need them. They've got an offer but can't ask policy, so the donor can offer the eggs to patients or to people that they think they would like to donate to, but no one can go up and ask anyone specifically for the eggs. I've been to presentations by these organisations. They're very passionate about what they do. I think it's a really good fit for some people, but in particular, I would recommend that anybody going through this sort of path gets independent advice, and I'll talk about how we can support patients by getting legal advice and some counselling, because again, whilst it all might seem great at the start, essentially you're entering an agreement with a stranger, and it's better to think about potential scenarios about how that could go bad prior to going into it, rather than later and finding out and experiencing that. And I think that that is definitely a responsibility of an experienced fertility specialist to be able to think about these scenarios, and more importantly, put them into touch with people and counsellors that can help workshop these issues and support them in that process. And it really is a process. The other option is offshore. Now, my highest recommendation is for the EVI Group. They are an international company, but started out in Spain. Spain has world-leading technology in IVF. This company, I have been to their lab in Valencia. Absolutely world-class, brilliant. Because they're an international company, they've got international focus and are great at dealing with international patients. They all speak English. They've got good email access, hours of support, brilliant. These donors, though, are anonymous, so there's no ability. So all registrations and sort of legislation in Australia does not apply. These patients need to go over to Valencia or Spain or wherever they go, and then fall under that jurisdiction. Most companies overseas will be anonymous donors, meaning you do find out some information about the donor, but not as much, and there's no ability for ongoing communication, particularly for the child when the child's 18, and I'll talk more about this later. That's a feature of the new Australian guidelines. The child must be able to contact the donor, or have the ability to contact the donor when the child's 18. None of that exists overseas. So that's a real point of difference, and something that will usually, make or break whether a patient is going to be suitable to explore that option overseas. Now, there is a Blastoise Guarantee with IVI of 2 blastocysts. Their donors are all young, and you also get all the eggs. So you may get well and truly more than 2 blastocysts. It's also much more affordable at around about $8,000 Australian. Again, though, you want to be legally aware of the issues of bringing a child in from that's been conceived like that from Australia. Thus far, there's never been an issue, but that doesn't mean there won't be in the future. And so, again, all of my patients are highly recommended to get independent legal advice, and I put them in touch with again, I get that if you refer, you're only as good as the doctor that you refer to, and so I've got a fantastic working relationship with some really experienced and good lawyers. So if we look at now sperm rather than eggs, sorry, I'm very happy to be able to offer patients in New South Wales access to brilliant sperm. So if we look at onshore and offshore options, I told you I've got an affiliation with Monash IVF, and again, I think it feels important for me to say this now, because I say it to all of my patients. is that I'm not employed by any fertility company. I'm an independent obstetrician and fertility specialist that has an affiliation, as anyone who works in fertility needs to, with the company. But I'm not spruiking on behalf of the company. My job is to support my patient in exploring all options and then helping them as best as I can to carry out that treatment plan. But fortunately, I'm with Monash IVF, which has many advantages and has a fantastic local donor bank. So it has 17 local donors with no wait list that patients can access. And in comparison, a lot of other companies have about 3 donors with a 6-month wait list or more. The sperm is only suitable for IVF. And I've written limited information on donors. Now, it's all relative. But again, I mean, these donors are coming in, they have to have counselling, they have to have infective screening, they have to donate. 3 months later, they have to come back and do the infective screening again. They don't get paid for any of this process. So there's not as much commercial drive to be able to say, now you've got to give us all of this information, you know, to sort of sell your sperm. It's not being sold, and therefore sort of more basic information is provided. It's still quite detailed, very much within the Australian guidelines. And again, when I write Australian compliant, it means that that donor has had to accept the fact that any child that's born from that sperm will have the ability to access their contact details when the child's 18. The same is not vice versa. The donor can't really go and seek out the child and to make contact, but if they elect to, they can find out if a child is born and the sex of that child. The biggest game changer recently that we've had on the lie of the land in sperm is access to international sperm banks. Now, we can bring that sperm here to Australia and use it as if it was produced in Australia, so meaning it meets all the legislative requirements and is Australian compliant, but it's from men that are based overseas. So I have an affiliation with the California Cryobank, which means patients of mine have access to an additional 60 donors. No wait list, and the sperm is IUI and IVF suitable. So there's plenty of women out there, or couples, that wish to try IUI first, and so therefore the sperm needs to be of a sufficient quality on post-thaw to be able to essentially behave like normal sperm. Now, with the commercial drive from the California Cryobank comes a fantastic amount of information. The California Cryobank can say to their sperm donors, listen, if you want to sell your sperm and you're getting paid for that, then we need this information to be able to do that. So what comes from that is, first of all, I'll show you what how the program works. So the process is that we work the patient up from sort of a medical point of view to make sure that everything's covered, and we've invested a thorough and methodical approach is always the best way of going about most things, but particularly when we're investigating fertility. You never want to be looking back thinking, oh, okay, now maybe we should do this. You know, it's better to do it all at the start and keep the patient informed as we're going, knowing why we're doing it and what position it'll get us in. The donor team at Monash IVF are fantastic at supporting patients through the sperm selection process, discussing the difference between the two donor programs, and then giving them access to the California Cryobank website. This is an example of that. All donors supply childhood photos, some supply adult photos. But they all supply a uniform amount of information, and it's amazing. So you get to hear the donor, a recorded interview. You get to 3 generations of medical history. There's an express yourself section where the donor writes what they like doing, sort of from a more artistic point of view. They're screened for 300 genetic conditions for the in vitro genetic carrier screen. They also have a standardized personality sort of test, a report from a psychological point of view, and physical appearance. So I would say that most people accessing donor sperm from the California Cryobank would know more from a medical point of view about their donor than they would their partner. So that's a fantastic asset. If we move on to objective number 2, so the legislative requirements for using donor sperm and donor eggs in New South Wales. So I've mentioned a few times by now that the offspring of any donor that's produced from sperm or eggs that are used in New South Wales must have the option to be able to contact the donor when the child turns 18. Now that also depends on the fact whether the parents tell the child that they're born from donor sperm or egg. And that, in my experience, seems very cultural. So there's some cultural backgrounds where it's a bit shameful to be using that sort of stuff, and they go into this process into me not telling the children. And one of my slides coming up is supporting patients as they explore the options they have in that regard, and in just the myriad of issues that using donor gametes can bring up. Now there's a 5-family limit in New South Wales, meaning one donor, whether it be local or California based, can only donate to 5 families. So each family can have as many kids as they like, but it's only 5 families. Now when a lady or a couple, a patient, orders sperm, that they're instantly considered a family, whether it's successful or not. That family space will become available if that patient isn't successful and chooses not to use that donor sperm anymore. But whilst they've got that sperm, they're a family. Nationally, a donor can contribute to 10 families, and internationally, it's really based on an honour system. So when they're registered or they're screened to be a donor, they say, have you donated anywhere else before? I also want to talk about patient supports and counselling requirements. I think this is super duper important. So in terms of the counselling requirements, anybody accessing donor egg or sperm in New South Wales needs to have at least 1 session of counselling with an ANZICA qualified, that means they've done a special course, counsellor. Yeah, that counsellor will then provide a report, which I uniformly pretty much approve, but really it's an information session, making sure that the patient realises what they're sort of entering into, any sort of law that's surrounding that, and sort of scratches the surface about how much research they've done on it and what their background is. I always recommend obtaining independent legal advice, particularly if you are using a known donor or, you know, Egg Donors Australia or anything like that. There's some brilliant people out here. I've got a photo here of Sarah Jefford, who is based in Melbourne, has been a surrogate, an egg donor herself, and is a legal eagle. So she has got a fantastic practice that supports people going through this process. There's also some other sort of more counsellor based, I mean, you know, just because they need the ANZICA certificate and they've qualified for that, it doesn't mean that we've really met the patient's needs in terms of how deep we've explored their issues about why they're using donor sperm, how they feel about it. And it's complex and can require more than just the 1 compulsory session. It's a fabulous lady called Miranda Montroni in Glebe who only does that sort of counselling. And she can workshop some ways and some scenarios, potentially thinking how would we tackle, or how would your group tackle some things you may not have thought about. What if you die? And then the donor says, okay, that's my child. Things like that. So when you're entering sort of known donor or even overseas donor sort of stuff, scenario workshopping can be really important. So it's about, again, creating a team that's going to be supportive and keep this patient informed, safe, and stepwise, in a stepwise fashion, approaching, you know, the best treatment plan for them. So I thought also we would talk about how we use donor sperm and donor eggs once we've accessed them. So eggs, obviously, it's going to be IVF. There's no other option. Usually, it's going to also be with ICSI, which is where we inject the sperm into the egg, which has no real implication on success rates or anything like that. I guess donor sperm, you've got a few more options. So if you use a local donor, it's been diluted in a way that IVF needs to happen with ICSI, which is told you what that is. Whereas if you use California Cryobank, IUI is an option. Now, what are the benefits of IUI? Well, it is less invasive. And again, this is a discussion that I have with my patients about the pros and cons of doing IUI versus IUI. Said it too many times. IUI versus IVF, yeah, and making a bit of a treatment plan. The thing is, you do need to think ahead because you've got to work out how much sperm to order from overseas, and shipping can be expensive, so it's not something we want to ship one vial at a time. So again, we sit down and work out pros and cons column, how it suits that particular patient, and then we come up with a treatment plan. Something that I did want to talk about, something I did want to talk about just quickly, because it's very relevant to all IVF cycles, is screening embryos that are made for chromosome abnormalities. There's been a real groundbreaking change in how we can do that now. Monash IVF has recently invented a technique where we can screen embryos for chromosome issues prior to transfer by doing it, sampling the fluid that they've been growing in for 5 days. We used to have to biopsy the embryo to do that. That could damage a good embryo and was very expensive, in the thousands of dollars. Now we can do it as $500 per embryo. It shortens the time to pregnancy because it means we don't waste time, energy, emotions, and money transferring embryos that never had a chance. Humans are particularly bad at producing embryos that are chromosomally normal. So since this technology has become available, and more and more, I would say now most people are screening embryos for chromosome issues prior to transfer. A big part of my job now is ringing up patients and telling them the results, and they, usually at least 50% of the embryos made, regardless of the patient's age, are chromosomally abnormal. So I highly recommend this to all of my patients and explain to them why. Back to donor. So cost. Yes, I've talked to you about my obsession with financial consent. And I think in this area, it's just as important. Patients can get very desperate, and that's totally understandable, and it's almost their job to be desperate. But I guess on the other side of the desk, my job is to be encouraging, realistic, but also having a more global view. The last thing that we want to do is put a patient in financial trouble for the rest of their life, and have just say yes, 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 without some sort of balance. So Monash IVF has a donor registration fee of $1,600. To access the local donor bank, that gets access to all donor banks and the support of the Monash IVF team. None of that money goes to me, is involved with me, but again, I act on behalf of the patient in terms of being their advocate should they have any questions or concerns with any of the stuff that goes on that side of the fence. Local donor sperm is $721 per vial, and one vial is one shot. Yeah, so this is where I always have a discussion with my patients, IUI versus IVF, because IUI seems cheaper at the start. It's $1,500, but the success rate is usually lower. And one vial will only fertilize that one egg that's naturally ovulated. Whereas IVF, with the intent of getting as many eggs as possible within reason, one vial of sperm will fertilize all of those eggs. So you get much more bang for your buck in terms of use of donor sperm with IVF compared to IUI. And when you combine that with the chance of success for both treatment plans, all of a sudden, this IUI that seemed cheap actually isn't. California Cryobank, it's around $1,500 Australian dollars, so 1,000 American per vial, and then we've got to pay for the shipping. Shipping is the same if you ship one vial versus 10. There is a bit of a discount. The more you buy, the cheaper the vials become. There's no minimum purchase, which is another fantastic feature of that program. Some other companies say you need to buy 10 vials. All of that donor supply, which gets frightfully expensive and is unfair. All donors from the California Cryobank have been screened for genetic conditions, so therefore on this side the patient also needs to be screened, and that costs around about $500. So how to start the process? So I think the patient should do their research. So even though different fertility companies will offer a different number of donors, and choice is important. Hey, if one fertility company offers only one donor, but that's the perfect donor for the patient, then fantastic. So knowledge is power. And again, you don't want to look back and think, oh, if only I explored a little bit more. Explore lots at the start. Gather your team and go for it. I think involving a fertility specialist early on in the process is a good idea. You need experience in this area to know where to look, how to look, and potentially how to educate, and that comes with experience. So I would say, pair your patient up with a fertility specialist who will help your patient look at different options and support them in achieving them. This is my website. I've put a lot of effort into hopefully making it obvious about the type of care that I like to give, both in obstetrics and fertility. I have different subheadings that you can see there. I don't know if you can see my arrow here with drop-down menus with some information about what I feel about all of these important things. And there is some buttons on the California Cryobank, IUI, EF, as well as the type of obstetric care that I like to give. Some contact details for me. I would love to share the care of your patients and any questions that you might have.
Yes, thank you, Dr. Tucker. The first question is, why do women need aspirin if using donor sperm?
No, I would say that they don't. So I wouldn't think there's any real strong correlation between those two things. I didn't hear all of Rahul's talk, but aspirin does decrease the risk of preeclampsia by up to 60%. Perhaps if you're using donor sperm and you're old, then that's a reason, but donor sperm doesn't equal universal use of aspirin in pregnancy.
Great, and the next question is, what happens to unused vials of donor sperm?
Good question. So when you order them, and I always, because of the shipping things, and often people, if they're not successful in the first few rounds, often want to go for another round. So I usually say consider buying, one more vial than you think you're probably going to need. Because the other thing is, there's no guarantee that that donor is going to donate again. Once you're a family for that donor, you'll always have access to that donor, but you can't make them donate. So the sperm might have run out. You can keep it forever, essentially. You can then give it to somebody else as long as there's a family space available, but you can't really sell it back. There's no refund policy.
Okay, the next question's a slightly longer one, but it's, what about people who donate eggs for an older mother to have her nucleus put in, so the younger cytoplasm has young mitochondria and increases success? What are the legal issues? Can friends do it? Do they have access? Are there rules regarding this?
So I think that's sort of absolutely on the edge of sort of technology and not something that we tend to do. Yeah, I think if people were thinking about doing all that sort of very complex things, they even more need somebody on their side to work out success rates. Where's this being done? Why aren't you using donor eggs and things like that? I mean, fertility is the absolute breeding ground for selling of snake oil. And I think as a patient, you need somebody on your side that can see through that and educate you. So that if someone's thinking about doing all that stuff, I would absolutely say get in front of a fertility specialist who has no vested interest in selling you any of this stuff. And as a team, analysing any evidence surrounding that sort of stuff and what your other options would be.
Great. The next question is, what are the current legal issues with surrogacy, such as minimum age of surrogate?
So surrogacy is something that I do, and it was a bit separate to this talk, but it's very difficult often to find it depends on the combination you need, but if you need an egg donor and a surrogate, it can be quite difficult to find the ideal one. So usually surrogates, we ask them that they've had a child before, rather than this be their first pregnancy. And yes, they can't be, you know, I think less than 21, I think I've said, but, you know, it's each taken on an individual basis. But we want to make sure that we're not only looking after the patient, but we're looking after the surrogate, the egg donor, all involved. And this again is where independent legal advice, the surrogate getting legal advice, the intended parents getting legal advice, and group counselling is super important. It's way better to make sure that everybody knows what they're getting into. I mean, that's not saying that's a bad thing. It's getting into a potentially fantastic thing. But workshopping all scenarios prior to going ahead with treatment and, you know, finding yourself in a sticky situation.
So the next question is there anything you like GPs to work up for a same-sex couple pre-fertility clinic appointment?
I don't think there's anything special for a same-sex couple as opposed to anybody else. But I always say, I mean, I completely recognise you've got a very difficult job as a GP. You don't have much time, and almost always the fertility specialist that you refer to is going to order another blood test. So I'm totally happy if I ever receive a referral that just says, hey, Justin, thank you for meeting these two people. This is what they're after, and, you know, thanks for helping. Like I was saying before, a thorough methodical approach is what's needed. And I always like to explain the test that I'm going to do, why I'm going to do it, and have my own special set of ones that I like. So don't feel bad is my point if you haven't done anything. Probably the ones that are most useful are a good quality pelvic ultrasound and a sperm test, if there's a male in this couple. But a good quality pelvic ultrasound and potentially an AMH, yeah? But again, we can always add that on.
Great. And the next question is, can you touch a bit on egg freezing, when it's best, how much it costs?
Yeah, so on my website, I've got a section about assessing your fertility, because I think every girl should sort of stop between the ages of 30 and 35, because I think you kind of know how things are headed at that age. And by far the most, the big issue that I think we're facing is women not being aware of the age decline that females have in their fertility. We spend all our time educating our kids on how not to get pregnant rather than the consequences of leaving it too late. Egg freezing. Sorry, Roy, can you repeat the question? It was what age?
Yeah, what age, how much does it cost? Just the general.
Yeah. So age, I think, you know, the younger the better, but I think, you know, between 30 and 35 optimum. Anything older than 40, the egg quality is not going to be as good. I've got a graph that I give all of my patients that relates the chance of success to the amount of eggs we get at different ages. And cost, depends if it's Medicare rebatable or not. So if they have a fertility issue and we can find a Medicare rebate reason, then it's about $5,500. Without a Medicare rebate, it's around about $10,000. But yes, my answer would be assess between 30 and 35, but definitely worth it up to the age of 40. And worthy of the conversation, more to the point. If someone's interested in their fertility and is worried about it, that's worthy of a 45-minute chat with a fertility specialist, I reckon.
Great. So the next question is, who is the mother on the birth certificate, the egg donor or the woman giving birth, and is the father the sperm donor?
Yeah, so that's I guess it depends what combination, and also where you're doing it. Yeah, but in general, and this is where like Sarah Jeffett and the legal team who know the international sort of setting is really good. But in general, the parents who are raising the child are on the birth certificate. Certainly here in Australia, that's the case. In America, that's the case. But in other countries, it varies.
The next question is, what helps a normal couple conceive, such as evidence for boxer shorts, ovulation test kits, avoiding cleaning chemicals, for example, Judy Ford's paper? Are they valid? What else can be suggested?
So this is a good question. And again, I think this is where it's, I do this every day when you sit down with a couple that are struggling to conceive. and to work out, first of all, what options they would have to increase the chances of natural conception. Now, I think, again, there's a lot of not great evidence out there, and we can say, okay, don't use the microwave, don't use Glad wrap, wear boxer shorts, don't breathe in anyone else's smoke, don't ever look at alcohol. And we set up this paradigm that is almost impossible to follow. These patients are already feeling anxious. Then the problem is then they break one of those things, they don't conceive, probably for a completely unrelated reason, and then they feel like that because they use the microwave, that's why they didn't conceive that time. Yeah, so I think it's very easy, therefore, to start placing blame, self-blame, by not following a list of things that we've given that's almost impossible to follow. I think the patients should be educated about where the money is. Yeah, what's the biggest problem? Has their fertility been thoroughly investigated? And what top 3 things are we going to do that we think is achievable, that's likely to actually translate into an increased success? And let's do them for this amount of time that we've agreed. And then if that doesn't work, we'll regroup and work out what the next steps are. I think we want to support patients, not just make everything harder.
The next question is, it's just one referral required for a same-sex couple?
Yeah. Yes.
And it looks like the last question is, what is the role, if any, of MTHFR and methylation in conception?
Yeah. So this constantly comes up, this one. So that's to do with folate metabolism. No studies have really proven that it has any impact on fertility. It's not one of the tests that we routinely run at the start of looking into the cause of potential subfertility. And I should have said before as well, in relation to the question about diet and things like that. I mean, we have governing bodies like the Fertility Society of Australia, the ESHRA group, the ASRM, the American-based one, the European-based group, that produce guidelines. And the reason they produce guidelines is to try and stamp out this sort of wishy-washiness that surrounds fertility. Yeah, I think it's important to be open-minded and take into account patients' values and beliefs. But when it comes to evidence, these guidelines provide security on both sides of the desk. Yeah, the doctor can say, listen, this is not just me saying this. This is a group of really clever people that have sat together and said, this is what we support. Yeah, it also means patients have got access to that and can say to doctors who are trying to sell them baloney, actually this is what it is. But hey, if screening for that is going to make the patient sort of feel more secure in their plan, then let's do it. Yeah, if it's an issue, let's acknowledge it, let's work it up and address it, rather than just dismissing it and then being in that patient's mind for the rest of potentially their lives, thinking, I reckon if I was screened for the MTHFR gene, things would have been different. Yeah, so I think it's all about listening to the patient, taking into account their values and working with that.